Good morning, everyone. I'll be talking today about transcatheter management of tricuspid regurgitation, what you need to know. By the end of this talk, you should be able to review the natural history and the relevant anatomy of tricuspid regurgitation, some of the highlights of echocardiographic evaluation of tricuspid regurgitation, and finally, we're going to review some of the current evidence for transcatheter interventions for TR. First, I want to state that tricuspid regurgitation is associated with heart outcomes, including overall mortality. In the largest study that I found here, a meta-analysis of 70 studies that included over 32,000 patients, those with at least moderate to severe tricuspid regurgitation compared to no or mild tricuspid regurgitation, had a significantly higher overall mortality. And the risk ratio here is almost 2. And even when you correct for other commonly associated conditions like RV dysfunction, systolic PA pressure, LV dysfunction, MR, atrial fibrillation, you can see the sustained impact of tricuspid regurgitation on overall mortality in all of these subgroups. These are the latest iteration of the guidelines, and they really don't comment on transcatheter interventions for obvious reasons, namely just is the inavailability of good quality evidence, and they mainly comment on surgical interventions for tricuspid regurgitation. So according to these guidelines, if you have severe TR and you're going for left-sided heart surgery, you have a class 1 indication for fixing the TR surgically, and that's the only class 1 recommendation in these guidelines. If you have RV dysfunction, though, or clinical RV failure, and you have primary TR, you have a two-way recommendation to fix that. And if you have secondary TR, poorly responsive to medical therapy, no left-sided causes or pulmonary hypertension, you can also consider fixing the tricuspid regurgitation surgically with a class 2A recommendation. The other group of patients that we often think about is those with less than severe tricuspid regurgitation going for left-sided surgery and having accompanied annular dilatation or right-sided failure. There is a two-way recommendation to fix the TR at the time of left-sided surgery. The problem is that it didn't really translate well into practice, mainly because of the poor quality evidence that's behind this recommendation, mainly based on observational studies. But there has been a study that was published recently this year in the New England Journal of Medicine after being presented in the recent AHA that basically looked at patients with moderate or less tricuspid regurgitation in patients going for surgery for degenerative mitral regurgitation. It was a multi-center RCT that randomized 401 patients in a 1-to-1 fashion to mitral surgery alone versus mitral surgery and tricuspid annuloplasty. The follow-up period was 2 years, and their primary endpoint was reoperation, disease progression, or death at 2 years. And the incidence of the primary endpoint was significantly more common in those who've had mitral valve surgery alone without tricuspid intervention. And the main difference was actually derived by the increased risk of disease progression or progression of tricuspid regurgitation in those who did not have their tricuspid valve fixed. The downside, though, is that those who've had the tricuspid annuloplasty, they had a significantly higher incidence of pacemaker implantation at last follow-up. The mortality was not significantly different between two groups, and the bypass time was only increased by 33.5 minutes on average. There was also no difference in major cardiovascular events, stroke, quality of life, NYHA functional capacity, or other adverse events. You might argue that 2 years is not really a significant follow-up period, and you might be correct, but there is a planned 5-year follow-up. The study, unfortunately, was not really powered to differentiate between moderate tricuspid regurgitation versus less than moderate or mild tricuspid regurgitation when it comes to these outcomes, but potentially further studies are needed. Now, going back to these guidelines, you might notice that they are quite conservative. And I've mentioned one of the causes is the lower quality evidence and observational studies, but one other cause is the unacceptable worse outcomes or bad outcomes associated with isolated tricuspid valve surgery. And this has been recently confirmed by a French study that included almost 500 patients, half of which had surgery for functional tricuspid regurgitation, and the other half for organic or primary tricuspid regurgitation. And what they have found is that the in-hospital mortality was about 10%, confirming the prior findings. In-hospital major cardiovascular complications were around 31%, and the overall survival-free of cardiovascular readmissions and survival-free of heart failure at 5 years was 75%, 44%, and 62%. Again, confirming our previous findings from older studies showing the unacceptable high risk for isolated tricuspid valve surgery. And the same authors also released something called the Tri-score, which is a scoring system that you can use to estimate the in-hospital mortality in those going for isolated tricuspid valve surgery. It's a good exercise to try to understand your population if you have someone that you're considering to send for a tricuspid valve intervention. Or to justify a transcatheter intervention, but you have to take this with a grain of salt in that I don't think this scoring system was actually externally validated in other populations. So you just have to keep that in mind. I tried to actually do it on a few of our patients that we discuss on Monday rounds, and consistently, most of them have a risk that exceeds 10% if we were to send them for isolated tricuspid valve surgery. Now, finally, looking at these guidelines, there's a few things that you might notice that in order to manage these patients, you really need to figure out a few things. I'm going to highlight them for you. Namely, you need to determine the TR etiology, the TR severity as well. And then you need to assess the RV function and clinically assess for signs of right-sided heart failure. You need to diagnose, determine the etiology of and severity of pulmonary hypertension. Now, this is the classic classification of tricuspid regurgitation. It's often divided into primary tricuspid regurgitation and secondary tricuspid regurgitation, which is further divided into secondary functional, ventricular functional tricuspid regurgitation or atrial functional tricuspid regurgitation. And here are some of the echocardiographic causes or echocardiographic example of primary tricuspid regurgitation. You have infective endocarditis, a flail leaflet either due to myxomatous disease or a side effect from a biopsy, carcinoid syndrome, rheumatic heart disease, and Epstein's anomaly. Epstein's anomaly is, as you guys all know, it's a congenital condition. Unfortunately, we don't have any transcatheter solutions for patients with Epstein anomaly, and it's often specifically named in the exclusion criteria for most of these interventions. When it comes to functional tricuspid regurgitation, this is a disease of the papillary muscles, the cords, the atria, and the ventricle. Now, the primary papillary muscle that supplies cords to both the anterior and posterior leaflets is the anterior papillary muscle. The posterior papillary muscle often has a variable anatomy. It can have 1, 2, 3 muscle bellies, with the septal leaflet often receiving its cords directly from the septal wall of the RV. And hopefully you can appreciate the complexity of the chordal anatomy of the tricuspid valve. It's also important to consider the anatomy of the tricuspid annulus. So it's a D-shaped structure. It's not really a true annulus. So if you actually put your finger through the tricuspid valve annulus in the OR, you won't feel a rigid structure or a fibrous structure like you would do for the mitral valve. And you often have these crisscrossing muscles that originate from the RV that inserts directly into the leaflets. Dilatation of either the RA or the RV can result in dilatation of the tricuspid valve annulus. The annulus itself is a very dynamic structure. It tends to increase in area and perimeter in diastole, and the circularity of the tricuspid annulus tends to reduce in diastole. So it's a very dynamic structure. And more importantly, there's this hinge-like motion throughout the cardiac cycle that's important in allowing the passive flow of blood into the RV. Now, with dilatation of the RA or the RV, the tricuspid annulus is typically dilated outwards, laterally and posteriorly. Also with the tricuspid valve annulus, it's very important to consider that it has a sagittal shape. So the atrial septal commissure, the anterior septal commissure is more atrial, whereas the posterior septal commissure tends to be more ventricular. And with further dilatation of the RV and the RA, you tend to lose that sagittal shape and it becomes more circular, which reduces the coaptation length and increases your risk of tricuspid regurgitation. This is a recent study that was published last year. It's based on 3D echo. So basically what they have done is they looked at 4 groups of patients, those with an isolated ventricular problems, and they used patients with tetralogy of Fallot as model patients, those with isolated right atrial problem, and those are patients with spared LVs and just a big right atrium, and a couple of groups with a combination of both. These are patients with pulmonary hypertension or left-sided heart disease. And what they have found is that annular dilatation and right atrial enlargement actually define the severity of the disease, as you can see with the C statistics scores here on the right. And then those who have further dilatation of the right ventricle, those have chordal tethering, displacement of the pap muscles, and you have more tenting volume, further increasing the severity of the tricuspid regurgitation. Comparing that to patients with isolated right atrial dilatation, they only have dilatation of the atrium and the annulus with relative sparing of the ventricle, and they tend to have less tenting volume. What about pacemaker or device-related tricuspid regurgitation? So it's defined by the increase in tricuspid regurgitation by 2 grades after device implantation. It's present in about 25% of patients, and it's also divided into primary and secondary. So primary is when there's a direct interaction between the device itself and either the leaflets or the subvalvular apparatus resulting in TR. Secondary is when you have remodeling of the RV and the RA, giving you functional tricuspid regurgitation. So some of the classic causes of primary device-related tricuspid regurgitation include leaflet impingement, leaflet adherence, laceration, avulsion, and also not only the leaflets, but also the subvalvular apparatus. You might have some chordal entanglement, rupture, perforation of the pap muscle, etc. So the pathology can be quite variable when it comes to device-related tricuspid regurgitation. And a couple of days ago, Becky Hahn actually proposed separating a device-related tricuspid regurgitation into its own category. So this, a couple of days ago, Becky Hahn published this paper in the European Heart Journal, where she proposed using a new classification system for tricuspid regurgitation, where you have primary TR, and then functional TR, which is again divided into atrial and ventricular, and then you have your own category of device-related tricuspid regurgitation. And this may not have a lot of clinical implication as to how we classify TR, but potentially when you're designing studies and clinical trials, you might need to take this into account. And why is this important? Well, it turns out that classifying patients with different etiologies of TR have different outcomes. So generally, it's been shown in multiple studies, including this one, that those with primary tricuspid regurgitation tend to have a slightly more favorable outcome than those with secondary tricuspid regurgitation, which is not only important in understanding our patients, but potentially, again, important in designing clinical trials and with choosing your outcomes in these clinical trials. Now, how do we grade a TR accurately? So the first thing I want to talk about is vena contracta. So vena contracta is where we measure the width of the jet at its narrowest point. We do that in the orthogonal views, so 4-chamber RV inflow view. And the typical or classical cutoff that's been described is 0.7 for severe. And you need to look at the conversion zone. You need to visualize it to accurately measure it. The problem with vena contracta is that it assumes a circular orifice, which is not always the case in tricuspid regurgitation. You tend to have a more complex regurgitant orifice, as you can see here in this picture down to the right. It tends to have an orifice that extends more in the anterior and posterior diameter, and this has been shown to be problematic. In the early feasibility trial of one of the annuloplasty devices in the SCOUT study, what they have found is that compared to the minimum vena contracta, the mean minimum, that it was 60% smaller than the mean maximum vena contracta. So you can really have a lot of variability. If you really don't look closely and try to average the vena contracta in your study, you may be underestimating your tricuspid regurgitation. Even further complicating this, the valve can really have a variable morphology and variable leaflet morphology. So you can have 2, 3, 4, 5, or even 6 leaflets, which can further complicate a linear measurement like vena contracta, especially if you're trying to accurately grade your tricuspid regurgitation. This is a new classification system or a proposal to define the anatomy of your tricuspid valve. So this was published by Becky Han late last year. So she divides the tricuspid valve into types. So type 1 is when you have 3 leaflets, type 2 is when you have 2 leaflets, type 3 is when you have 4 leaflets, and 4 if you have 5 leaflets. And basically you identify the leaflets using the following. So the intraventricular septum would define your septal leaflets. The anterior septal commissure would is defined by the aortic valve. And then the more important, or the other important landmark is the anterior path muscle. So the leaflet that's attached to the septum is your septal leaflet. And then the leaflets that between the anterior septal commissure and the anterior path muscle would be your anterior leaflet. And then the leaflet between the anterior path muscle and the posterior septal commissure would be your posterior leaflet. Essentially what was found is that a type 1 valve is the most common type of valve. And it's very useful, especially in people are involved in structural interventions, to actually exercise trying to classify these patients, because it helps you look more closely at the anatomy of the valve. And this is an example of a patient that we discussed last Monday in valve rounds. And you can see here that the anterior most path muscle is probably here. So this is the anterior path muscle. So if you look at another picture for that patient, so this is the location of the anterior path muscle. So between the anterior septal commissure and that path muscle, this would be the anterior leaflet, and you can see that it's scalloped a little bit. So you can, and then between the anterior path muscle and the posterior septal commissure, this would be your posterior leaflet, and finally here is your septal leaflet. And so for this patient, I would classify them as a type 3A because they have a scalloped anterior leaflet. The other parameter is EROA by PISA, which again is problematic in that it assumes a circular orifice, which is not the case with tricuspid regurgitation. So your PISA is non-hemispheric in shape, especially in secondary tricuspid regurgitation, which can lead to underestimation of TR. And you tend to have a more ellipsoid orifice, so the PISA is hemi-elliptical, which can result in underestimation of your tricuspid regurgitation. But the good thing about EROA is that it's actually associated with outcomes. So multiple studies have shown, including these 2 studies, that the higher EROA, the worse are your outcomes. And if you have EROAs that are in at least the moderate range, so 0.3 or above, you start to see worse outcomes in your patients. So it continues to be an important parameter to measure. 3D vena contracta has been well correlated with 2D EROA as well as regurgitant volume, as you guys see here, and in multiple other studies. And it's been increasingly studied as an important tool in evaluating the severity of tricuspid regurgitation. And potentially in the current pivotal clinical trials, we might see some association with outcomes. Also, I want to say that compared with 3D vena contracta, the PISA EROA was found to be underestimating the severity of TR in 40 to 50% in these studies. So this is a summary of some of the parameters that we have mentioned. I want to highlight the IVC and the hepatic vein. So we often say that flow reversal, systolic reversal in the hepatic vein is associated with severe TR. And if you actually look at the original studies, it's actually associated with moderate or severe tricuspid regurgitation. And it's not very specific if you have retrograde conduction, a paced rhythm, or atrial fibrillation. The other thing I want to highlight again one last time is that if you're going to use vena contracta to grade your tricuspid regurgitation, especially someone with significant TR, you probably should be taking the mean from multiple views. PISA will continue to be an important method as it's associated with outcomes. And 3D vena contracta is easy, especially if you're using, if you're doing a TEE. So you can get that from your MPR. and it is an increasingly important tool in grading tricuspid regurgitation. So it's often been seen that patients with tricuspid regurgitation, those who are in their late stages of the disease, have clinical signs of right-sided heart failure and resistance to diuretics. And papers as early as this is an example of a paper from the European Association for Echo. In their document, they do describe that massive TR that's associated with a low jet velocity as there is near equalization of the RV and RA pressure, and that's associated with a triangular jet. So there's always been this feeling that there are patients with typical severe TR and patients who are slightly have worse or a higher end of severe tricuspid regurgitation. The other thing is that in early feasibility studies of transcatheter interventions, it was found that those who have a reduction in TR within the severe range, so even after intervention, if they still have severe TR, they still have some meaningful clinical improvement. And this is an example on the right side here of the SCOUT study, which looked at the TriAlign device, which is a suture-based annuloplasty device. And you can see here that patients who have a moderate tricuspid regurgitation post-intervention have better outcome compared to severe TR or torrential tricuspid regurgitation. This is a new classification system that's proposed by Becky Hand back in 2017, where she breaks down the severity of breaks down severe TR into severe, massive, and torrential tricuspid regurgitation, which is useful, especially when we're starting pivotal clinical trials, to look at the potential benefit of reduction of tricuspid regurgitation from torrential to massive or from massive to severe. And 2 days ago, she actually released a new iteration of the same classification where she introduced a new class of significant or moderate to severe tricuspid regurgitation. I know that we already use this terminology, but it's now official. And she introduced it into the classification system. She also introduced regurgitant volume as a way of, grading the severity of tricuspid regurgitation, as well as 3D echo regurgitant fraction. So very useful for the cardiology residents and the echo fellows to look at this new classification system, as I'm sure it's going to be increasingly more relevant. The current iteration of the guidelines, they merely mention the new classification system, but my understanding is that the European Association of Cardiovascular Imaging guidelines, which are currently in press, are going to recommend using the new classification system in their latest document. What about RV function? So we don't really have a perfect way of assessing RV function routinely right now. So a few of the methods that we know about, so TAPSE technically measures the RV basal function. This also applies to the S prime. Fractional area change is good, but the problem is that there's a lot of inter-reader variability. The other parameter that can be used and can easily actually be used if you have the right software is the RV strain. And there's actually a nice paper that came out just a few days ago in the European Heart Journal that gives you a step-by-step approach of how to acquire RV strain. And it also highlights some of the common pitfalls with interpreting RV strain. And it gives you some normal values that you can often refer to if you're actually using this for your patients. And I want to highlight here this last study that included 2,000 patients and used machines, including Philips machines, and utilizing TomTec software, which we have here. The lower limit of normal for the 3-segment free wall RV strain is -20 and -18 for the 6-segment RV strain. What about RVEF? So RVEF has been associated, has been well correlated very well with cardiac MRI, even in patients with atrial fibrillation. And it's also been associated with outcomes. So in this of 150 patients who underwent 3D echo as well as MRI. You can see that with MRI or completely automated 3D echo or RVEF derived from 3D echo versus RVEF derived by 3D echo with some manual editing, all of these methods showed EFs that correlate with outcomes, and really the difference between the different parameters are not that significant. So there are some minor changes when it comes to volumes if you use CMR versus echo, but in reality, these numbers are not really that different from each other. Some people say, the RV stroke volume and ejection fraction is significantly impacted by afterload. And some people say that potentially an important parameter is a parameter that utilizes both contractility and afterload. And we can measure the RV-PA coupling invasively by generating these PV loops. You can use that to derive the ventricular end-systolic elastance, which measures contractility, and divide that by the PA arterial elastance, which assesses afterload. But you can also derive this non-invasively using echo. So if you utilize, you can divide the TAPSE by the RVSP to generate a RV-PA coupling ratio. This has been actually studied, and there is a paper that came out just a few days ago that looked at RV-PA coupling and outcomes after a tricuspid valve intervention. And the interventions here included both annuloplasty devices as well as transcatheter edge-to-edge repair. And it was found that those with a high baseline RV-PA coupling ratio, so a higher baseline TAPSE over RVSP ratio of more than 0.41, so you have more contractility and more afterload reserve, you have a reduced mortality at last follow-up. And in these patients, it's often been shown is that post-clipping or post-tricuspid intervention, the RV-PA coupling ratio tends to further drop. And this may indicate that these patients have more afterload reserve. And with the increased in forward stroke volume, you have a higher afterload, giving you that picture of a reduced RV-PA coupling ratio. Whereas those patients with a lower PA coupling ratio at baseline, so less than or equals to 0.41, they have a higher all-cause mortality at last follow-up, and they tend to not have any changes after the procedure with their RV-PA coupling ratio. And these are some Kaplan-Meier curves here on the right side, again demonstrating that a higher baseline RV-PA coupling ratio is associated with better outcomes than those with a lower ratio. And those with a further drop in their RV-PA coupling ratio tends to have better outcomes compared to those who don't. And the p-values here were both significant. Now, I want to talk about some transcatheter interventions. So first, I want to talk about some annuloplasty devices. So the first device I want to talk about is the Tri-Align device, which is a suture-based annuloplasty device. So it's been shown to effectively reduce the severity of tricuspid regurgitation, but down to a modest range. But even that modest change, and you can see here that the average vena contracta pre and post is still within the severe range, and the same applies for EROA. It's still translated into meaningful clinical outcomes, so significant improvement with NYHA functional capacity, quality of life scores, and 6-minute walk tests. But I really haven't seen a lot of studies published on this device since 2017 for reasons that I will mention in a bit. The other annuloplasty device, a ring annuloplasty device, is the Cardioband device. So with a study of an early feasibility study published just last year, that showed that it was very effective in reducing the severity of tricuspid regurgitation. And even though about half of the patient remained within severe massive or torrential tricuspid regurgitation, the improvement in NYHA functional capacity, so NYHA class 1 or 2 was 32%, increased significantly to 75% at last follow-up, as well as the overall quality of life scores. So again, this highlights the fact that even though you might have patients that would improve in their TR from torrential only down to massive or severe, this can often translate into meaningful clinical improvement. Now, challenges with these annuloplasty devices that There's no distinct fibrous annulus, as we've discussed earlier, so we tend to run into issues with dehiscence. It's less effective when the primary pathology is related to RV dilatation and leaflet tethering. RCA perforation has been reported with these patients that undergo this procedure, and often the imaging is quite difficult, and you end up needing to use ice to implant these devices. So it's, in short, it's a pain to implant annuloplasty devices, and so far they're not as promising as edge-to-edge devices or replacement devices. Now, edge-to-edge devices, I want to talk about the Pascal device, and the CLASP early feasibility study was published also last year. I know that the earliest experience with this device was actually here at St. Michael's Hospital, with the initial paper was authored by Dr. Pham. And you can see that the device was quite effective in reducing the severity of tricuspid regurgitation, with a technical success exceeding 90%. But still, significant proportion of these patients remain within severe massive or torrential tricuspid regurgitation. But despite that, there was significant clinical improvement with TR with NYHA class 1 to 2 functional capacity patients were up to 98%. The Triluminate early feasibility study also showed a similar efficacy of their device. This is a different device from Abbott, so it's the same as the MitraClip device, but it has a special guide that's used to implant these devices in the tricuspid position. It just allows for better maneuvering. And what the device, what the early feasibility study shows is that it was very effective in reducing the severity of tricuspid regurgitation. And again, despite the fact there's a significant proportion of patients remained within severe massive or torrential tricuspid regurgitation, there was significant clinical improvement at 30 days and then again at 6 months. And the 1-year follow-up study was again published last year, and what the study has shown in these initial 85 patients is that there was a 40% reduction in hospitalizations of heart failure at 1 year of follow-up, and there is a sustained durability of repair at 1 year of follow-up that exceeds 85%. So very promising early results from the Triluminate study, and actually what the study has shown is that the risk of heart failure hospitalizations or death in these patients who sustain a TR of moderate or less at last follow-up was significantly reduced. And here at St. Michael's Hospital, we're actually involved in the Triluminate pivotal trial, which randomizes patients to medical therapy versus device therapy. The main inclusion criteria that you might want to think about is that you need to have asymptomatic patients on optimal medical therapy as judged by your local team for at least 30 days. And the main exclusion criteria, and the exclusion criteria are extensive, but the main ones that you need to think about is a systolic PA pressure of more than 70, a fixed precapillary pulmonary hypertension, a poor prognosis if you think that the patient won't survive for a year, or if they are in end-stage renal disease, for example, or an advanced malignancy, and also anatomical non-feasibility. So again, you have these Epstein patients, calcified leaflets, or a large coaptation gap that's more than 20 millimeters. So what are some of the relative contraindication for edge-to-edge repair? So these are some of the things that we think about on Monday rounds. So if you have a patient with thick leaflets or very short leaflets, so less than 7 millimeters, actually the smallest clip device, the NT, requires at least 6 millimeters of tissue to be able to grasp effectively. If you have leaflet destruction from endocarditis, for example, a large flail gap, or significant tethering of more than 9 millimeters, those would be patients where you tend to run into issues when you're actually trying to clipping them. Patients with a large coaptation gap of more than 8.5 millimeters at the target, again, tend to be very difficult to clip. And one of the things that we look at when we do a right-sided heart cath is the PA pressure, is the RA pressure. And if the RA pressure is high, we can often pre-admit these patients and diurese them to try to shrink down that coaptation gap potentially to facilitate the clipping procedure. If there's lead-related TR, if it's very localized around the lead and there's no remodeling that happened, it tends to be difficult to try to clip these patients, and we often don't. And one of the things that you can do if there was some difficulty with proceeding with lead extraction or repositioning, or it was contraindicated, is that you can think about transcatheter replacement. Anatomical complexity, so depends on the number of leaflets, the density of cords. If associated with massive or torrential tricuspid regurgitation, again, these patients tend to be more difficult. You have difficult imaging, signs of RV remodeling. So if you have a pooped out RV, we don't really, the benefit from the procedure at that point is questionable. We still try, but patient might continue to feel to be symptomatic after the procedure. And then those with left-sided heart disease that's amenable to medical therapy, it's always best to medically optimize your patients to try to avoid an intervention and only intervene in patients who absolutely need to have an intervention. What about a transcatheter replacement? So this is the TriSend feasibility study that looked at one of the valves that we implant here at St. Michael's Hospital, and that's the Evoke valve. So these are 25 patients, and the device really showed that it can nearly obliterate tricuspid regurgitation and significantly improve NYHA functional capacity here. And you can see that the vast majority of patients post-procedurally have an NYHA class 1 to 2. And now the TriSend single arm study has stopped recruiting. We were participating in that study. So the only study that you can use to implant this device in your patient is the TriSend 2 pivotal trial. So in these patients, you have a 50-50 chance of being randomized to medical therapy alone. So if you absolutely need to have a valve replacement, potentially need to implant a cardio valve, and I'll show you an example for that in a second. So this is one of the patients that we implanted an Evoke valve into, and we implanted several of these valves in our patients. And you can see here that post-implantation, you have a well-seated valve with no significant paravalvular regurgitation. This is the MR jet and the aortic valve jet. And this is an example of a patient in whom we implanted a cardio valve and not an Evoke valve. So a cardio valve is still kind of enrolling in its early feasibility study. So if we have a patient with either a large annulus too big for Evoke, so we're talking annulus more than 52 millimeters and up to 54 millimeters, or patients who cannot be randomized to medical therapy, we tend to refer them or consider them for a cardio valve procedure. And this is an example of this valve, and we implant these valves here at St. Michael's Hospital. I think that we have actually an implantation being planned for next Tuesday if you want to join us in the OR. So challenges with tricuspid valve replacement. So patients, again, with large annuli, we often have patients who have more than 54 millimeters, and currently there's no valve for those patients. So if we really need to have a valve replacement for a patient with a larger annulus, we tend to diurese them potentially as an inpatient, then repeat the CT scan, and then readmit them for diuresis prior to valve implantation, just to facilitate the implantation procedure itself. You have to rely on excellent intraprocedural imaging, which is often easier said than done, especially in patients who have a lot of shadowing from the interatrial septum, or they have some mitral hardware. And also, you need to keep in mind that it's the bundle of His runs just posterior to the anteroseptal commissure. So with a transcatheter valve replacement, you can run into conduction abnormalities, and you may have an increased risk of requiring a pacemaker implantation. And then we don't have a lot of information about durability for these devices, as they're quite new and recently developed. So this is just an overview view of all the other devices available for the tricuspid valve, and there are many. But I think the devices that show the most promise are edge-to-edge repair devices like the Pascal or the TriClip, and valve replacement devices like the Evoke and the cardio valve, all of which we implant here at St. Michael's Hospital. So future goals for the heart valve team is to increase the awareness for TR and its prognosis, and to assist with developing and utilizing quantitative tools, especially those that are associated with outcomes like 3D vena contracta, EROA, 3D EF. To develop an appropriate management strategy, hopefully that's evidence-based, and I think it's important to develop your local management strategy according to based on your local available resources. Here at St. Michael's Hospital, you can refer a patient to the heart valve team, and we would be happy in assisting you in managing your patients. The other thing is that we need to be able to risk stratify these patients and fully understand the pathology to be able to choose the appropriate intervention for the patient. And then more importantly, we need to determine the outcomes out of these interventions, the outcomes and the benefit from these interventions to be able to better inform our patients and continue to provide these devices. So this is everything that I had. Thank you very much, and I'm very happy to answer any questions.
Thank you, Anas, for this very, very comprehensive review of the tricuspid valve. And I'll ask my question first, and then I'll get my colleagues to ask their questions. So which is the best view for measuring the vena contracta? If you have to choose one, or we should use an integrated multiple views to look at the vena contracta on transthoracic?
So thank you. I think that's a great question. And what from my reading so far and my experience is that from all these available orthogonal views and then just average those, and that's a better reflection than just simply using a single view every single time, just to avoid any potential underestimation, to try to get the wider jets. So measuring all of them and then averaging them, like they did with the SCOUT study, is potentially the best approach. And that's what the recent paper from Becky Hahn also suggests doing. Which is, I understand that it's easier said than done, especially if we're in a lab that has 60 studies a day. It's may not be the most efficient way of doing it, but if we are utilizing vena contracta in patients with significant tricuspid regurgitation, we're not really using it simply to rule out significant TR. I think that would be the best way to do it.
And as is Howard, if I can add to that, first of all, thanks for the talk. That was fantastic review, and I guess I had a comment about the vena contracta, and then I had a question for you. So the comment is, the vena contracta is challenging sometimes, and from a spatial resolution standpoint, it's better to try and measure it where the flow is perpendicular to the beam. It's a bit more challenging when it's parallel, where it tends to spread out a little bit. So the apical views versus, let's say, the parasternal views. And the other comment about the vena contracta is, if you're averaging it, you're probably going to exclude the views where you have multiple commissures. For example, that parasternal short axis, almost the tricom view where the jet looks massive, and you really can't get a good discrete vena contracta. Would you have any comments about those issues?
Yeah, I definitely agree. Like with that, the multi-commissural view, I'm sure the jet is likely going to be. And I agree, even though that was no one really commented on the practical aspect of it, including that aspect. I'm sure you're going to probably be overestimating the severity if you're using that view, and so I think that's a great point to consider when measuring the vena contracta, and I agree. And the lateral resolution, as you mentioned, is important, especially with the tricuspid valve. It tends to be a challenge, and it may impact the accuracy of the vena contracta. And I agree with that, and they did comment on that in the recent documents for assessment of TR severity.
Wow, that's great. And a question just to remind us, for those who don't do the interventional echo aspects, in the T's pre tricuspid intervention, whether it's CLIP or TTVR, what are some of the key views on the preoperative TEE that you as an imager who guide the procedures is important for us to capture, particularly the grasping views? Could you review those with us briefly?
Yeah. The first view would be the transgastric on fast, because it really helps us understand the anatomy. And one of the things that really significantly prolongs the procedure is when there is a complicated anatomy of the valve and you have a lot of leaflets, and we tend to clip into clefts and between or into commissures, which can be quite challenging. Is if you have a patient with 4 or 5 leaflets, and we tend to run into that problem actually. And even though in the mid-esophageal views, it looks like you're really approaching the leaflets appropriately, if you have a complex anatomy of the valve, you can be unknowingly trying to clip into clefts and commissures. And so we really use that transgastric view to try to decide, even preoperatively, where exactly we're going to clip and where exactly we're going to try to avoid to be. So I would say number 1 is the transgastric view. The second view is the bicommissural view, or the 60-degree view, and just explaining through that. That's the most helpful view from a 2D perspective in helping us kind of identify where exactly is the jet is coming from. Is it more central? Is it central and anteroseptal? And then, and it also helps us decide where we should probably start clipping a patient. And sometimes the GE junction bicommissural view is much better, simply because there's less tissue between the probe and the tricuspid valve. So it's I think at the beginning of the study, it's useful to compare the bicom view both in the mid-esophageal and the GE junction. And some of the actual clinical trial core labs started asking us just recently, I heard that last week, that they want us to routinely add in both mid-esophageal and GE junction views, just because the GE junction views are sometimes, in some patients, strikingly more beautiful in showing you the leaflets, the tricuspid, the leaflets without any shadowing, and the image quality is sometimes just great. And then the last thing would be 3D, with the aortic valve being orientated at around 11 to 12 o'clock. And again, it just helps us try to localize the jet and confirm our the appropriateness of our plan of where we actually are going to try to clip first.
Thank you.
Hi, Anas. It's Vesna. Thank you for the great talk. I just have a question about something that I didn't realize until recently. I find that the gap, the malcoaptation gap we get, is most often widest at the sort of, if you measure anterior to posterior leaflet, which is useless from a interventional perspective. So for the Triluminate trial, you mentioned that a contraindication is a 20 millimeter malcoaptation gap. I think that's what you said. Now, would that be measured between the AP, sorry, the like at the anteroseptal or posterior-septal commissure?
So we measured at the target. So if we're targeting the anteroseptal commissure, so you would measure, that's where you would measure the coaptation gap. So
okay,
that's why it's a little bit tricky when you're only using non-explained like 2D images, because you don't know exactly where is that gap that you're seeing. Is it central, or is it something that's between in your target or not in your target? So no, the contraindication is based on your target. So most commonly we target the anteroseptal commissure, and we do that in more than 90% of our patients, and we actually know that number. I recently looked at it for one of my studies, yes, that's what essentially that's where you would look if you're planning to clip anteroseptally, which we do for most patients. That's where you would measure the coaptation gap. Yeah.
So can you still have, like, let's say you have a bigger gap between the AP, but a smaller one at the target, you would still clip that? Okay.
That's right.
And then
that's right.
where? sorry, you mentioned that you want to get that gap on X-plane. So that would be, you know, like if we're transgastric, we have our tricom, bicom view at 60 degrees, and that's where we would measure, or do you measure the gap at the on-fast view?
So we use a combination of everything, and they usually correlate with each other. So if I think the on-fast view is really good, I measure there, and then I correlate that with the X-planes through that area and try to make sure that I'm getting the same number. And then also from the mid-esophageal, let's say I'm looking at a gap between the anterior and septal commissure. I try to look at that X-plane that's explaining anterior septal and try to measure the gap there also from the mid-esophageal. And if the images are good quality, they tend to all correlate with each other. And then one more thing that I'm going to mention, and thanks for bringing up this topic, is you tend to have an annuloplasty effect. So that's the other reason. If you have a central gap that's big and you clip anteroseptally, it's very common to see that the valve is all brought together, especially if you start clipping in the anteroseptal commissure. I think that's because of there's a small fibrous structure to that annulus that's localized there. And if you clip there, you kind of bring all the valve together. And we see that more in the anteroseptally than when you clip elsewhere. So if there's not a significant gap anteroseptally with a significant gap centrally, you can have an annuloplasty effect just by clipping anterior septal, and you can reduce that central gap eventually. So the most important gap is the gap that you find at the target. And if you're in doubt and it's not primary TR, the usual target is anterior septal.
Actually, to that point, Anas, is there data to suggest that there are patients who have positive remodeling after a clip and have further reduction in tricuspid regurgitation severity because of that annuloplasty effect and reduced volume from reduction in tricuspid regurg?
Yes, so there is data. If you look at that with the 1 year follow-up from the Triluminate study, there is a special section in that paper for RV remodeling, and you can appreciate that both the RA and RV side have shrunk down, and there is a slight further reduction in the severity of tricuspid regurgitation at 1 year of follow-up compared to 6 months of follow-up. And we've seen it also in our patients for one of my projects you can clearly see that the RV and the RA has shrunken down in the vast majority of our patients post the successful intervention.
Do you know if they've subdivided into the atrial versus the ventricular versus combined functional TR? That would be interesting.
I'm not aware of any data, and I don't think it's out there yet, but I definitely think that this will be a very hot topic like it is right now for the mitral valve. Yeah.
So, Anas, thank you for all your wonderful answers and to the questions. Do you think, in addition to many of the parameters that we do right now, so for selecting patients for tricuspid valve regurgitation procedures, do you think we should routinely do RV strain, or is there a role in doing RV strain on a regular basis?
Not necessarily for, I wouldn't say there's not a lot of data that suggests a benefit from doing RV strain on all patients with valvular intervention, but I know that RV strain is increasingly becoming utilized for assessment of function and with other specific indications for it, like following patients with some sort of myocardial disease. So right now, if we measure it for every single patient, it would be useful for academic reasons. It would give us an edge when it comes to research. But I think that in the near future, just because of the ease of measuring RV strain and RV or 3D-EF, we've had a loaner machine from Philips last year. And they showed us that how easy really it is to measure RV-EF and RV strain in just a few clicks after the study is done. There's no special acquisitions that you need to do. It's just based on your regular imaging protocol, and you can add RV strain and RV or 3D-EF on top of your study using TomTech software on the machine. So I think just because of the ease of use, it's going to become more utilized. And as more data becomes available for the efficacy and the utility of these measurements, I think it's going to be increasingly utilized. But right now, should we utilize it for every clip patients? I don't think I have the data for that, but it would be nice to have it to have an edge when it comes to publishing studies and doing research.
So I guess the point is when the new machine comes, and because it is actually ordered, and also we have Tomtec subscription, and whether we can combine both and to be able to do that more routinely and without a lot more extra steps, that will be quite interesting to do it routinely among patients who have a significant tricuspid regurgitation or MR even.
Yeah, I hope so too.
Something to work on. Okay, well, we're hitting around 8:58. Any other questions? Last words? So, and thank you for, once again, a very, very comprehensive review of the forgotten valve, so as to say, and it's taken many, many years for this to come. Now people are really focusing on tricuspid valve with all the new technology and also many of the excellent academic colleagues and wonderful devices that has been developed by the biomedical engineering field, and it's really truly amazing seeing a renaissance of this valve that has been ignored for many, many years. So thank you.